Right, Sabah al Khair. It's a pleasure again to be back here with all of you, talking on a slightly different topic about antithyroid drug duration therapy in patients with Graves' disease. Now, before we start, can I just ask what your usual practice is? Just so raise your hands if you treat people with Graves' disease with antithyroid drugs for 12 to 18 months, generally. 2, 3, 4, 5. So about 10, 15, maybe 10%. Less than 12 months. 1. You're a really small minority, my friend. More than 18 months. 1. Okay. Yeah. 3, 4 years? No one? It depends. Who would say it depends? On the patients and their characteristics and so on. Yeah, okay. I'm really interested to know about the others who haven't raised their hands. So you won't treat them for less than 12 months. You won't treat them for 12 to 18 months. You won't treat them for up to 3 or 4 years. So what do you say? You don't treat them with antithyroid drugs? Okay, who doesn't treat with antithyroid drugs and just gives radioactive iodine? Okay. Or surgery? No? Okay, this is slightly confusing for me. So anyway, so it's I mean, interesting. I think I got the biggest raise of hands for the 12 to 18 months, so which is kind of standard practice for most people. So I think what I'll try and do the next half an hour is try and see what is the optimum duration of treatment we should be aiming for in these patients. And that's a really important question, because when the patients come to see you, they have this question: how long is the treatment going to be for, doctor? And I think we need to have that conversation to set expectations right at the beginning. So Graves' disease, I'm sure you all know, one of the other questions that a lot of patients have is it dangerous? Is it severe? Basically, because when you say Graves' disease, the first thing that comes to mind is where they'll end up in a few years' time. And it's really important to explain to them it isn't really about the location. It's named after an Irish physician, Robert Graves, who I think it was 1890s, I forget the exact date, but around the 1890s, he came across this constellation of symptoms of an overactive thyroid, large goiter, and eye disease. And this constellation came around the same time as Basedow was coming up with his constellation of symptoms. So some people call it Basedow's disease, but more commonly, Graves is what it's synonymous with. It's caused, as we've just heard, due to autoantibodies against the TSH receptor, and there can be 3 kinds of traps. Stimulatory, which is the most common that we see in practice; blocking, which you do see occasionally, but 10% can be blocking, which can present with hypothyroidism, and some of them can be neither blocking or stimulatory. They're neutral. So you can measure them, but they won't be causing any clinical or biochemical abnormality. So the trap might be elevated, but the TSH and T4 might be normal. That's because it's not 50-50 blocking and stimulatory, which is also possible, but it's also because it might be neutral antibodies that we are measuring. Outside of research, it's very difficult to actually be able to measure whether it's stimulatory or blocking in kind of commercial assays that are available. It's probably the most common cause of hyperthyroidism, Graves' disease is. Can occur at any age, but it's most common in women between the ages of 20 to 40 or 50. And TRAbs are also the reason for why Graves' orbitopathy develops in these patients. And also pretibial myxedema, not to forget. So the usual options that we have are antithyroid drugs, and we've got 2 or 3 options, depending on where you practice and what you believe in terms of the evidence and the patient. Radioactive iodine, which has, and it's still kind of pushed by a lot of people as the most cost-effective way of managing these patients. And near-total thyroidectomy is also a reasonable option in some of our patients. So these 3 options are always there and have been there for a while. If you just look at antithyroid drugs for now, the first drug that was used was propylthiouracil in the 1940s. The others, methimazole and carbimazole, then came around a decade later. The duration of treatment is only for a few months initially. And then over time, the duration increased and is now roughly between a year to 2 years, and especially that's due to the high recurrence rate that we find in these patients. And the risk of relapse, again, it depends on which literature, but on average, in most patients, about 50%. It depends on how long you want to follow them up. At 12 months, most studies would be about 30 to 40%. Longer duration of follow-up is on average about 50% of patients that will have a relapse. So what are the pros and cons of radioactive iodine versus antithyroid drugs versus surgery? So the pros for antithyroid drugs is straightforward. It's a tablet that they take. There's a good chance of that they'll achieve a euthyroidism. The side effects are the disadvantages, or the possible side effects, I must say. As we've heard, the risk of agranulocytosis, in theory, is meant to be 3 in 1,000, but I think it depends hugely on the dose that is used. So higher the dose is used, higher the risk. The other thing that we have to keep in mind is that sometimes, particularly at the beginning of treatment, mild transient neutropenia is not uncommon because of the thyrotoxicosis per se, rather than the carbimazole. So it's very unlikely somebody who's received 1 dose or 2 doses of carbimazole will actually have neutropenia. It's very, very unlikely. Generally, it tends to happen in about a few weeks after starting treatment. And there's no way of predicting who will benefit. There are some Japanese papers that suggest HLA typing may be useful, but that's not, again, available in routine clinical practice. As we've seen, 40 to 50% will be euthyroid. There's a small risk of hepatic failure with PTU. Then you have the cost of appointments and the blood testing and so on, long term, that we have to consider. Radioactive iodine is effective in the vast majority. 90% will be either hypo or euthyroid post-radioactive iodine. There's a kind of certainty to the outcome once you give the radioactive iodine. It's cost-effective, and a lot of health economic studies have shown this. The disadvantages are that nearly everyone will be hypothyroid, requiring lifelong levothyroxine. Subsequently, there's a risk of transient hyperthyroidism post-radioactive iodine in some of these patients, and that's due to the release of TRAbs. There's worsening of Graves' orbitopathy, which is a concern in some of these patients. The rise in TRAb levels is seen, and there's many studies that show post-radioactive iodine TRAbs rise quite significantly. And there's also evidence that suggests that post-radioactive iodine weight gain is much more. So, as I said, 90% become hypothyroid. Some remain hyperthyroids. There's contraindications in pregnancy and with children around. It's all that practical side of things as well. Surgery, certainty of outcome in nearly every patient. I've yet to see somebody who's had total thyroidectomy and still has a recurrence of the thyrotoxicosis. It means that you need to change the surgeon if that happens. It's a preferred method or modality of treatment in people with large goiters or who have severe or active Graves' orbitopathy, and you want quick control of their hyperthyroidism, and antithyroid drugs are not very effective in this. The downside, as I'm sure you all are aware, are the surgical risks with recurrent laryngeal nerve and hypoparathyroidism and so on and so forth. So, I mentioned about weight gain after radioactive iodine, and on average, post-radioactive iodine, the average weight gain compared to, say, somebody on long-term antithyroid drugs is about 4 to 5 kilograms higher in these patients. So we have to keep this in mind. For a lot of our patients, we don't really mention weight gain as a possible side effect of radioactive iodine. We always mention hypothyroidism, but this is something that a lot of women are rightly concerned about. So I think we should have that as one of the downsides, if you like, of radioactive iodine. There's this interesting study that looked at quality of life in people treated by various modalities, so radioactive iodine versus surgery versus antithyroid drugs. And what is interesting is if you see these 100 is worse, so the higher it reaches the outside perimeter, the worse is that quality of life for that domain. And you'll see that for a lot of these, for radioactive iodine and surgery, it's much higher typically than antithyroid drugs. So quality of life seems to be better preserved with antithyroid drugs than it is with the other two modalities. So I think there are certain advantages to be had in considering antithyroid drug treatment in our patients. I mentioned TRAb levels. Again, as we see with medications and also with surgery, there's a similar reduction with both these treatments. But with radioactive iodine, there's a very much slower reduction in TRAbs as time goes on. And that's typically because of the release of thyroid tissue post-radioactive iodine, leading to more autoantigen being present and higher TRAb. And therefore, that explains the risk of post-radioactive iodine Graves' orbitopathy in these patients, because the TRAb levels are generally much higher in this group. There is a score, I'm sure you're all aware, that was from Amsterdam, called the GRADE score, and then there's the GRADE plus score. So I've not really gone too much in the GRADE plus score, because then you need HLA typing to be able to achieve that. But for the GRADE score, age, the levels of free T4, the levels of TRAb, the size of the goiter, and so on were used. And you could have either a low score of 0 to 1, a middle score of 2 to 3, or a score of high, which was 4 to 6, called class 1, class 2, or class 3. And using that, it became apparent that that could predict the risk of relapse for a significant number of our patients. So it has a fairly decent sensitivity and specificity in trying to predict which patients might be suitable for what modality of treatment. So just consider having, we probably all use this, but this is a more structured way of being able to assess the risk of relapse in our patients. What about just using TRAb as a predictor of relapse? So on the left of the screen, you'll have the risk of relapse with TRAbs at diagnosis of the condition, and to the right of your screen is the TRAbs at when you consider stopping treatment with antithyroid drugs. And both seem to be equally effective in how to predict. So those with the highest TRAb levels, either at diagnosis or at the time of stopping antithyroid drugs, have the highest risk of relapse of their Graves' disease. And those with the lowest levels have the lowest risk of relapse. And that, again, isn't surprising. What about long-term antithyroid drug treatment in Graves'? So a lot of these studies are relatively new. This is a concept that's been around for a while, but it's only recent that a lot of researchers are looking at 3 years, 4 years, 5 years of treatment with antithyroid drugs and what happens. And what you see is that after 12 or 18 months, which is kind of standard practice, in this study, patients were then randomized to either receive long-term methimazole, or they were discontinued treatment. So it was randomly allocated after the 12 to 18 months. So the baseline of 0 is when they are meant to stop, or when they are randomized. So that isn't at diagnosis. So 0 is when they have completed their 12 to 18 months of treatment. Then they are randomized to either continuing with antithyroid drugs or stopping the antithyroid drugs. And as you'll see, the risk of relapse obviously is much higher in patients that have that have discontinued treatment, and it's much lower in people who continue. Now, one thing to keep in mind is this is very low dose methimazole. So in terms of carbimazole, it'd probably be about 5 milligrams a day on average that we are talking about in this group. So again, suggesting that for some patients, long-term treatment may be an option. And the risk of side effects, we'll look at that in a minute. So again, there's another study, as I said, from Faridoon Azizi, not that far from here in Tehran, who looked at this. This wasn't a randomized controlled trial. This was more an observational study, again, showing a similar higher risk of relapse in people who discontinued treatment compared to people who continued on long-term antithyroid drug at a low dose. What about the course of TRAB antibodies in patients with grave disease? So what's interesting is that the majority, and I say majority, but 50 to 60% of patients follow a predictable course. So at diagnosis, levels are high, you start treatment, and the TRAB levels fall down and continue to be down and almost normal for good few years. There are some, but a significant proportion, 30 to 40%, that come down, but then for some reason, inexplicably, then go high and then come low. And we see this quite frequently in practice. Patients come in, they're taking their medications, but if you just follow the TRABs, at one visit it'll be 3, at the next visit it'll be 9. And then 6 months later, it'll be down to 3 or 4 again. And there is no actual explanation that we find. Sometimes it might be stress, sometimes it might be smoking, but it's difficult to actually pinpoint what it is. And then there are the small percentage, about 1 in 10, that despite what you do, the TRABs remain high. And that's about 10% of these patients. And I think this is the group that's really high risk of developing a relapse if you were to stop their antithyroid drugs at any point in that time course. Risk of relapse with duration, as I said, 50%, about 18 months if you were to stop treatment. If you were to continue treatment for about 4 years, it's about the same, 45%. More than 5 years treatment, there's a good chance that TRABs, whatever they were at diagnosis, would have come down. So the risk of relapse, this is again an observational study, but suggests that it's probably lowest with long-term drug treatment. There are obvious concerns with this kind of design. It's not randomized control, it's observational, selection bias and all that, but just suggests that that might be an option to consider. Remission rate, again, these are all the studies that continued treatment long-term, and you'll see overall risk of relapse is about 43%, which means that remission rate is about 57% in any study that treated patients for more than 18 months to 2 years. Smoking, we know that, again, this is an observational study from Edinburgh where they looked at smokers versus non-smokers on people on treatment with antithyroid drugs and found that smokers had a consistently higher level of TRABs than non-smokers. Again, we find this very, very routinely in clinical practice. And I've seen this many times. You explain this to the patient, miraculously they stop smoking, happens rarely, and then you find that the TRAB levels that have been consistently 10 or 15, 6 months later is down to 2, 3, and potentially even normalizes. And this is the patient that was previously difficult to manage. T4, T3 levels don't really differ that much if you follow them for long enough, although it does take a longer time to achieve normality with T4 and T3 in people who smoke. What about safety? I mean, this is the question that I get asked when I say, but what about the risk of with carbimazole? And I think the first thing to say is that any treatment has its risk. It's not as if surgery doesn't have any risks. It's not as if radioactive iodine doesn't have risks. But antithyroid drugs, like any other chemical, has its own risks. A systematic review of all the published literature of 12 studies of more than 1,500 patients with grave disease, out of those 1,600 patients, 14 patients developed major complications, which works out to about 0.8%. So less than 1% will have what are termed as major complications. And how do they define major? Anything that is either requires hospitalization or life-threatening. And that was, about 0.4% of those were agranulocytosis, 0.3% was severe liver damage, 1 was ANCA-associated glomerulonephritis, 1 was vasculitis related to PTU treatment. So again, I think if you are weighing up the pros and cons, I think a 0.8% risk, in my view, is worth bearing in mind in these patients. And the one patient who developed vasculitis was after 6 years of PTU therapy. And no major complication occurred in the first 12 months I think, is an important point to note. Again, the risk is higher with increasing doses. So if you try and go for the minimum effective dose, which is either 50 milligrams of PTU or 5 milligrams of carbimazole, which works for the majority of patients, I think it tends to be quite effective. So what would I suggest, how we manage people with Graves' disease? I think we have to pick and choose who we think about this. But if there are patients that we think might benefit from long-term antithyroid drug treatment, I think this is how I suggest, and again, this is just a suggestion, we need to find which patient is suitable. This may not be suitable for everyone. If the patient prefers to have a known outcome, then it's probably better to go with either radioactive iodine or surgery, because you know for certain that they will have hypothyroidism, or nearly all with radioactive iodine will have hypothyroidism. And again, there's a lot of patients who may not be suitable or who may not be keen for either surgery or radioactive iodine for their own, whatever their personal preferences might be. And those patients that were less likely to achieve remission. So people with large goiters or really high TRAB antibodies at baseline. And you know that even if you treat them for 4 or 5 years, it's not really going to make a huge difference. And I suspect then long-term antithyroid drugs may not be suitable. I think we should aim for the lowest possible dose for safety in these patients. And as I've said, the suggested dose of carbimazole PTU is up there. I think we need to evaluate regularly the patient. Once they are established on antithyroid drugs and we have decided that they'll continue on this for a good few years, I would see them once a year. Obviously they can contact us if they have issues, but the vast majority have no issues. And if they are stable and they are unlikely to achieve remission, and they're going to stay on antithyroid drugs for the next 10 years or so, maybe we don't even need to see them and they can be managed in primary care. Again, a suggestion, you don't have to take it if you feel uncomfortable about that. So in summary, duration of antithyroid drug therapy should be patient-centric. It isn't a one-size-fits-all. Not every patient requires 12 to 18 months. I have some patients that come back after 6 months and their TRABs have become undetectable, and I stopped the antithyroid drugs in those. And the risk of relapse is no higher than patients who have continued for 12 to 18 months. So my clinical practice is to monitor the TRAB levels, and at the point where I think I'm able to discontinue antithyroid drugs, I measure the TRAB. If it's normalized, then I discontinue treatment. I gather that it's not as easy here to measure TRAB, and I was just asking Dr. Hussain about this, and he suggested that it's either sent to Dubai or across to Europe, so it's expensive and it takes time. So again, it may be something worth exploring, because if you use the Roche assay, for example, Roche has the same platform measures TRABs. So there's no reason why the Roche assay can't be used to measure TRABs. So I think having that discussion with the biochemists is probably, again, I think it comes down to volumes and how much there is an appetite to do this. But I find measuring TRABs an invaluable tool in managing patients. TRABs are the best indicator, as I've said. Some patients with low TRAB levels at a diagnosis, as I said, can discontinue treatment within 6 months of starting treatment. Most patients require 12 to 18 months. Some patients may need long-term antithyroid drug therapy, and in these patients, the pros and cons of all three approaches should be considered. So I think to answer the question, what is the most optimal duration of treatment, my answer would be there's no one-size-fits-all. It depends on the patients, it depends on their preferences, it depends on their presentation, and it depends critically and crucially, I would say, on what's happening with their TRAB levels, both at diagnosis and at the time of considering cessation. So, thank you very much.